Reconstructive surgery is performed to restore function and normal appearance, and correct deformities created by birth defects, trauma, or medical conditions including cancer. Reconstruction midface, lefort eye, single piece, segment movement in any direction, e.g., for long face syndrome, without bone graft. 2 pieces, segment movement in any direction, without bone graft. 3 or more pieces, segment movement in any direction, without bone graft. Reconstruction midface, lefort eye, single piece, segment movement in any direction, requiring bone grafts, includes obtaining autografts. 2 pieces, segment movement in any direction, requiring bone grafts, includes obtaining autografts, e.g., ungrafted unilateral alveolar cleft. 3 or more pieces, segment movement in any direction, requiring bone grafts, includes obtaining autografts, e.g., ungrafted bilateral alveolar cleft or multiple osteotomies. The physician performs a lefort eye osteotomy to repair congenital malformations or acquired deformities of the facial bones, without using a bone graft. With the patient under anesthesia, the physician makes a horizontal cut through the maxillary sinuses and nasal septum through an intraoral incision, and into the pterygoid fissure. Surgical instruments are used to complete the separation of the maxilla from the skull base. The maxilla is down fractured to mobilize it and can be moved into the proper predetermined position. If segmental surgery in the maxilla was necessary, the mobilized segments are held in position by a template secured to the upper teeth. Maxillary malpositioning is corrected and the maxilla is wired to the mandible, which is positioned as a whole unit. Rigid fixation of the maxilla is achieved with mini plates or intermaxillary wires. The operative site is irrigated with antibiotic solution and the oral mucosa is closed as needed. Reconstruction midface, lefort 2, anterior intrusion, e.g., Treacher-Collins syndrome. Any direction, requiring bone grafts, includes obtaining autografts. Reconstruction midface, lefort 3, extracranial, any type, requiring bone grafts, includes obtaining autografts, without lefort eye. With lefort eye, the physician reconstructs both the midface and the maxilla to correct developmental or acquired skeletal deformities. The physician uses a variety of incisions, including a bicoronal scalp flap, lower eyelid, and transoral incisions. Complete separation of the midface, lefort 3, from the cranial base is necessary. Additionally, horizontal down fracture of the maxilla is necessary to correct alignment of the teeth. Surgical fractures are made through the zygomas, orbits, and bones of the nasofrontal region with saws, burrs, or osteotomes. The physician also makes a horizontal osteotomy, separating the maxilla from the midface. The midface is down fractured from the stable cranial base and the maxilla is down fractured from the midface segment. Both the midface and the maxilla are placed into new positions and reduced with wires, plates, and or screws. The physician harvests bone grafts from the patient's hip, rib, or skull, and closes the surgically created wound. The interpositional bone grafts are placed between the bony interfaces of the maxilla and the midface. The transoral incisions are closed in a single layer. Lower eyelid and scalp incisions are closed in layers. Intermaxillary fixation may be applied. Reconstruction midface, lefort 3, extra and intracranial, with forward advancement, e.g., monoblock, requiring bone grafts, includes obtaining autografts, without lefort I. With lefort I, the physician reconstructs the midface with the forehead to correct developmental or acquired skeletal deformities. Surgical fractures are made through the zygomas, frontal bone, and orbits. Complete separation of the midface with the frontal bone from the cranial base is necessary. The physician uses a variety of incisions, including a bicoronal scalp flap, eyelid, and transoral incisions. Osteotomies of the complete midface, lefort 3, together with the frontal bone are performed with saws, burrs, or osteotomes. The midface with the frontal bone is down fractured from the stable cranial base. The midface and frontal bone are placed with precise measurement into new positions and reduced with wires, plates, and slash or screws. The physician harvests bone grafts from the patient's hip, rib, or skull and closes the surgically created wound. The interpositional bone grafts are placed between the bony interfaces of the newly positioned midface and forehead segment. The transoral incisions are closed in a single layer. Eyelid and scalp incisions are closed in layers. Intermaxillary fixation may be applied. Reconstruction midface, osteotomies, other than lefort type, and bone grafts, includes obtaining autografts. The physician reconstructs the midface to correct developmental or traumatic skeletal deformities. Reconstruction includes both osteotomies and bone grafts. The physician may use a variety of incisions, including a bicoronal scalp flap, eyelid, and transoral incisions. Through the incisions, the physician performs osteotomies as necessary of the midface with saws, burrs, or osteotomes. The midfacial bones are down fractured from the stable cranial base. The midface is placed with precise measurement into a new position. Bone grafts are harvested from the patient's hip, rib, or skull and the surgically created wound is closed. The interpositional bone grafts are placed between the bony interfaces of the repositioned maxilla and midface. Internal fixation devices such as wires, plates, and screws are used to hold the reduction securely in place. The transoral incisions are closed in a single layer. Eyelid and scalp incisions are closed in layers. Intermaxillary fixation may be applied. Reconstruction of mandible, extraoral, with transosteal bone plate, e.g., mandibular staple bone plate. The physician reconstructs the mandible by inserting a bone plate with posts that extend through the lower border of the mandible and into the mouth. The posts can be used to retain dentures in an atrophic or thin mandible. The physician makes an incision through the skin under the chin and dissects the tissues to the bone. Holes are drilled upward through the bone and into the mouth. The posts of the plate are placed through the holes and into the mouth. The plate is secured extraorally to the mandible with screws and the incision is closed with layered sutures. Reconstruction of mandible or maxilla, subperiosteal implant, partial. Complete. The physician places a metal framework between the mucosa and the bone of the maxilla or mandible. The metal framework has posts that extend vertically and protrude through the mucosa into the mouth. The posts are used to retain an upper denture in the maxilla or lower denture in the mandible when teeth are missing. Intraoral surgery is performed in 1 or 2 sessions. The physician makes an incision along the crest of the edentulous area, without teeth, and exposes as much of the bone as possible. If performed in 2 sessions, the physician makes impressions of the exposed bone and sutures the mucosa closed. The impression is used to make models for custom framework. At the second surgical session, the physician removes the sutures and again exposes the bone. The metal framework, with the attached posts, is placed on the bone. The mucosa and periosteum are sutured over the framework and around the protruding posts. Scarring, which occurs with healing, keeps the framework in place. If performed in one session, a CT scan is used to make a plastic model of the mandible or maxilla from which the framework and posts are fabricated. A single surgical session is used to insert the framework as described above. Incisions are closed simply with sutures. Reconstruction of mandibular condyle with bone and cartilage autografts includes obtaining grafts, e.g., for hemifacial microsomia. The physician reconstructs the mandibular condyle of the temporomandibular joint, TMJ, using bone and cartilage taken from the rib. The physician harvests the rib by making a small incision through the pectoralis major muscle and dissecting through the tissue to the rib. Part of the rib and the cartilage near the sternum are removed. The donor site is closed with layered sutures. The physician makes incisions through the skin anterior to the contour of the ear and dissects tissue to the TMJ site. Another incision is often made beneath the angle of the mandible and the tissue is dissected to the bone. The bone is exposed superiorly as far as possible. The rib graft is inserted through the lower incision with the cartilaginous end placed upward into the joint, replacing the condyle. Through both incisions, the rib is manipulated into the proper position and secured to the mandible using plates, screws, or wires. The incisions are closed with layered sutures. Reconstruction of mandible or maxilla, endo steel implant, e.g., blade, cylinder, partial. Complete. The physician places metal implants into the bone of the maxilla or mandible. Metal posts attached to the implants protrude through the mucosa into the mouth. Artificial teeth or dentures are attached to the roots to replace missing teeth. These implants may be cylindrical or thin blades. The physician makes incisions through the mucosa to expose the bone using an intraoral approach. Precision holes are drilled in the bone where the implants are to be placed. With blade-style implants, the posts are already attached to the implant and the mucosa is sutured simply around the post. With cylindrical implants, the mucosa is sutured over the top of the implant and is allowed to heal while buried under the mucosa. The incisions are closed simply. A second procedure is performed 3 to 8 months later. The implant is exposed again and the abutment connectors are attached. Report 21248 for partial reconstruction. Report 21249 for complete reconstruction. An endosteel implant is a type of dental implant that's put in your jawbone as an artificial root to hold a replacement tooth. Reconstruction superior lateral orbital rim and lower forehead, advancement or alteration, with or without grafts, includes obtaining autografts. The physician performs reconstructive surgery on the lower forehead and superior lateral orbit of the eye to correct skeletal abnormalities, with or without grafts. The physician may use a variety of incisions, including through the eyelids and scalp, to obtain access to the site. The soft tissues are dissected as needed to expose the bones. The physician performs osteotomies of the forehead and orbit as needed. The bones are manipulated and realigned to the desired position. The physician may obtain bone grafts from the patient's hip, rib, or skull that can be placed to augment the forehead and orbit reconstruction. The bones are held in place with the use of wires, plates, or screws. The wounds are irrigated and each closed in layers. Reconstruction, bifrontal, superior lateral orbital rims and lower forehead, advancement or alteration, e.g., plagiocephaly, trigonocephaly, brachycephaly, with or without grafts, includes obtaining autografts. The physician performs reconstructive surgery on the lower forehead and both superior lateral orbital rims to correct skeletal abnormalities of the cranium, with or without grafts. The physician utilizes a variety of incisions about the eyes, forehead, and scalp to gain access to these bones. The soft tissues are dissected as needed to expose the bones. The bones are manipulated, contoured, and shifted as needed to place them in the desired positions. The physician may obtain bone grafts from the patient's hip, rib, or skull that can be placed to augment the reconstruction. Various internal fixation devices are employed to hold the reduction rigidly in place, such as wires, pins, plates, or screws. The wounds are irrigated and closed in layers. Reconstruction, entire or majority of forehead and / or supraorbital rims, with grafts, allograft or prosthetic material. With autograft, includes obtaining grafts. The physician performs reconstructive surgery of the forehead and the supraorbital rims of both eyes to correct skeletal deformities of the cranium. With the patient under anesthesia, the physician uses any of a variety of incisions about the eyes, forehead, and scalp to gain access to these bones. The soft tissues are dissected as needed to expose the bones. Osteotomies of the bones are performed in multiple places to facilitate manipulating the bones into the desired position. The bones are shaped as needed. In 21179, the physician utilizes allografts or synthetic prosthetic material to augment the reconstruction. In 21180, the physician employs autografts, harvested from the patient's hip, rib, or skull. Pins, wires, plates, and screws are used to hold the bones and graft in rigid reduction. The wounds are irrigated and closed in layers. Reconstruction by contouring of benign tumor of cranial bones, e.g., fibrous dysplasia, extracranial. The physician performs surgery to correct distortion, expansion or deformity of a cranial bone caused by a benign extracranial lesion. The physician utilizes any of a variety of incisions to access the site. The incisions are carried deep to the bone and the tumor is identified and exposed. The physician uses surgical instruments to debride, reshape, and contour the cranial bone to conform to its normal anatomic position and profile. The bone and wounds are irrigated and closed in layers. The physician performs reconstructive surgery of the cranial bones including the orbit walls and rims, forehead, and nasoethmoid complex following the excision of benign tumors from within and without the cranium. The physician utilizes a variety of incisions through the mouth, eyelids, and scalp to gain access to these bones. Reconstruction of orbital walls, rims, forehead, nasoethmoid complex following intra- and extracranial excision of benign tumor of cranial bone, e.g., fibrous dysplasia, with multiple autografts, includes obtaining grafts. Total area of bone grafting less than 40 sq/cm. Total area of bone grafting greater than 40 sq/cm but less than 80 sq/cm. Total area of bone grafting greater than 80 sq/cm. The incisions are carried deep, soft tissues are reflected, and the bones are individually identified and exposed. Osteotomies are performed as needed to surgically fracture and manipulate the bones into their desired and acceptable positions. This may require advancement of the forehead. Bone grafts are harvested from a site such as the hip, skull, or ribs. Multiple grafts may be required to augment and stabilize the reconstructed cranial bones following tumor removal. Internal fixation devices such as wires, plates, and screws are used to hold the reduction securely in place. The incisions are all irrigated and closed in layers. Report if the total area of bone grafting is less than 40 sqcm, 21,183 if the total area of bone grafting is greater than 40 sqcm but less than 80 sqcm, and 21,184 if the total area of bone grafting is greater than 80 sqcm.